friend of mine had acute chest pain. He was admitted to a hospital. His basic tests were reported as normal. No arterial blockage test was planned. I know this because I was constantly in touch with him on Messenger. And then he was discharged after being told that this was most likely acidity. And the next morning, he died. I don't really know who was at fault or what went wrong, but this question has remained with me. This incident made me think about the limits of the tests conducted at a hospital emergency departments. No immediate danger is not the same thing as safe. It only means that nothing critical has been found yet. So when your symptoms say one thing and your test results say another, what do you do next? A patient who comes to a hospital emergency with possible heart symptoms usually has two questions. Am I in immediate danger? And what is wrong with me? Now, hospital emergency tests are not designed to answer the second question. They are designed to answer the first one about whether there's any immediate danger, like a heart attack. And typically, tests for a heart attack include an ECG, which looks for electrical signs of an ongoing or recent heart attack, and a troponin blood test, which looks for heart muscle injury. Here's the problem. Sometimes, early in a heart attack, both ECG and troponin can show up as normal. Troponin rises over time. So very early tests may not show it yet, and ECG changes can fluctuate or be delayed. So the standard emergency practice, if tests are normal while symptoms persist, is to observe the patient and repeat both tests in a few hours. If for some reason this does not happen, and the patient is discharged while symptoms still persist, what can the patient do? Any or all of the following. Clearly tell the doctor on duty that symptoms are still persisting and ask for reassessment and for repeat tests. Seek care at another hospital immediately, self-arranged if needed. Ask the doctor on duty whether it is safe for you to chew aspirin at this point, since it's not safe for everyone. If moving to another hospital, call an ambulance instead of self-transport if symptoms worsen or feel unstable. If the patient is not discharged, here are some scenarios that can happen next. Scenario 1, a heart attack is confirmed and the patient is advised an angiogram, sometimes immediately. An angiogram can help answer the second question as well, about whether there's something else lurking underneath, like arterial blockage. Scenario 2. A heart attack is ruled out, but the patient is advised further tests, which again are supposed to answer both the questions, provided the advised tests include arterial blockage tests. Scenario 3. A heart attack is ruled out and the patient is discharged without further advice. And this is the dicey grey zone, because it answers the first question about immediate danger, but does not address the second question about whether there could be any lurking cardiac problem with the patient, which may have caused the symptoms and which could risk leading to a heart attack in the future. Now, the only way to directly confirm arterial blockage is through these two blockage detecting tests. A coronary angiography, which is invasive, and a CT coronary angiography, which is non-invasive and uses contrast dye and radiation. These tests are generally safe, but they do involve a contrast dye and radiation. So doctors weigh the small risk against how much the test result will actually help the patient and sometimes decide not to prescribe these tests. A CT coronary calcium score can be done to detect calcified plaque only. It helps with risk assessment, but not with measuring blockage severity. All the three tests I mentioned have to be prescribed by a doctor. A patient cannot self-order them without a doctor's prescription. So, if your symptoms persist or recur and you don't have an explanation for them, And I mean symptoms such as chest pain or pressure that returns, discomfort that comes with exertion or stress, symptoms like sweating, breathlessness or nausea, pain that moves to the jaw, arm or back, symptoms that are new and unlike anything you've had before. And if you have known risk factors for heart disease, such as family history, smoking, high cholesterol, high BP, high blood sugar, or excess weight, then you have a fair, legitimate reason to question whether arterial blockage has truly been ruled out. So what are your options now? Tell your attending doctor that your symptoms have not gone, about your existing cardiac risk factors, about your family history, and ask if you should be tested for blocked arteries, and if not, why not? If the doctors at the first hospital decline your request or don't give you a satisfactory answer, get yourself to a different hospital emergency. Clearly state your symptoms and if they have persisted, recurred or changed, and your known heart risk factors. Seek a consultation with a cardiologist, share the emergency episode, your current symptoms, and your personal and family cardiac risk factors. Ask one focused question. Given my symptoms and risk, should my coronary arteries be evaluated? And if you're still not satisfied, you can seek more opinions, preferably after asking someone you trust for cardiologist recommendations. Patients cannot self-order arterial imaging without a doctor's prescription, and they cannot force someone to do a test. And that is about as far as a patient can go. I hope that helped some of you. Lots more confusion clearing for heart patients coming up. Take care.